Okay, so remember our aspiration, what we're wanting to achieve is cancer outcomes which are comparable with the best in the world. And I just want to share some sort of overarching key messages with you to begin with. And the first one is that we believe that as an action team, along with the Cancer Intelligence Network, we can support those of you that are responsible for commissioning cancer services to save lives, to improve the quality of life of patients who have been diagnosed with cancer, to improve the experience of care that they have, and to ensure that we get the best value for the money that we're spending on the delivery of cancer care. The second key message is that currently we believe that cancer patients all over this country are dying unnecessarily. It's not just in deprived areas, it's everywhere. And we think that there are about 10,000 avoidable deaths if survival in this country was to match the best in Europe. And if we were to match the average in Europe, then we think there are about 5,000 lives that we could be saving each year. And that's a target that we've set ourselves to achieve by as early as 2014-15. And as I've already said, the NHS spends about £6 billion a year on cancer services. But we think that the investment in cancer services is inefficient, and there are areas where we should be redirecting resources away from and new areas that we should be investing in. And I'll say a bit more about that in a moment. We also think that there are a number of myths about cancer that we want to address and to respond to. And the first myth is that cancer has had more than its fair share of growth in recent years within the NHS. Well, actually, spend on cancer accounts for about 6% of the NHS budget, and that has been a static figure in recent times. It hasn't increased. So there isn't evidence that, in fact, there's been significant growth within cancer services. A second myth is that too much attention has been given to cancer. We've made significant progress and we ought to be turning our efforts to other disease areas. Well, survival following a diagnosis of cancer in this country, as I've already commented, is poorer than in many other parts of Europe and other parts of the world. And we believe that earlier diagnosis of this disease could save a significant number of lives. Third myth is that cancer is a secondary and tertiary issue. It's not really got much to do with primary care and care in the community. Well, again, we would argue that primary care has a significant role to play in major parts of the patient pathway, whether that be at diagnosis, in terms of ongoing support, or end-of-life care, which we're going to hear a bit more about this afternoon. Fourth myth, all cancer interventions are highly expensive. Well, again, many of those interventions that in fact have the greatest impact, things like smoking cessation, screening, early diagnosis, are a very effective use of resources. It's true that some chemotherapy that's given at the end of life care is less cost effective, and that's something that we're looking to address. But you'll find that many interventions do have a significant impact at a very reasonable cost. And the fifth myth is that interventions for cancer only prolong life by a few weeks or a few months. Well, we believe that earlier diagnosis of cancer, earlier intervention, can actually make the difference between early death and prolonged survival and, in some cases, cure. So those are some of the myths that we think are around that we want to ensure that those that are responsible for commissioning hear and know what the responses to those myths are. One of the things that has been raised with myself, members of the team, and with Mike Richards, as we've had some earlier conversations with commissioners, is, well, just tell us what it is we should be disinvesting in, and tell us what it is we should be investing in the future. And I'm going to come back to some of these things in a moment, but just to highlight, to summarise at the outset, some of the things that we think we should be disinvesting in, if you like, moving money away from, is firstly reducing the number of emergency admissions that we see at the moment. And we can do that by better proactive support, things like acute oncology services, ambulatory services for symptom control. We can reduce lengths of stay in hospital again, there's evidence that the lengths of stay in hospital in this country are far greater than in many of our partner countries. And by introducing things like the Enhanced Recovery Programme, we can make significant inroads into the lengths of stay. And we can reduce ongoing follow-up for survivors of cancer through promotion of supported self-management following a period of primary treatment. So those are areas where we think we should be moving money out of. In terms of investment, we think we should be investing in early diagnosis and in increased day case surgery. But all of this has to be done within the context of where we are today. And I've just highlighted 4 things there. Firstly, the NHS reforms. Well, it doesn't need me to tell you where we are in terms of the amount of uncertainty, the problems that we're facing during this transitional period, lack of clarity about future roles and responsibilities, new commissioners trying to get to grips with the task that faces them. And that's true for us as a National Cancer Action Team. We believe that we're going to something called the Improvement Body, which is an arm's length part of the Commissioning Board, but exactly what our function will be in the future and whether we'll be retained as a sort of corporate identity is still to be resolved. And the risk for us is that we become so consumed, I guess, with thinking about the next 9 to 12 months that we take our eye off the ball. We've got some very specific challenges that are set out in the Improving Outcomes Strategy for Cancer, like the saving 5,000 lives each year by 2014-15. So we need to make sure that despite the uncertainties that we're facing about our future, both as individuals or as teams, as services, that we continue to ensure that we drive forward to realise the ambition that I've mentioned earlier. In terms of the financial challenge, well, there's still this need to save this £20 billion in terms of services across the NHS that can be reinvested. And that's a huge challenge for the service as a whole. If you think about cancer services, back in 2010, the National Audit Office undertook a study of commissioning of cancer care. And one of their main conclusions was to say that there was a lack of understanding within the service about what drives cost in cancer care. We were not able to say how much it costs to deliver chemotherapy services. We weren't able to say how much it costs to deliver radiotherapy treatment. And clearly, that is a major shortcoming. If we don't know how much things that we're trying to commission cost, then we're going to be very challenged in trying to commission effectively. And so there's a need for us to have a better information, better understanding on cost. We need to identify those areas where we think we can make significant investment and those areas where we should be disinvesting. So that's the financial challenge. When I originally prepared these slides, I was saying, of course, we're still waiting for the information strategy. And on the train to Leeds, the information strategy came out, so I had to change the slides instantly. But we now know what the power of information strategy says. And in terms of cancer services and information, we want to focus on the need to measure outcomes, on measuring those processes that are linked to outcomes, and ensuring that information is widely available to commissioners, to providers, to the users of our services, both in a timely way, an accurate way, and in a way that they can find accessible and they can find that information useful. One of the keys for us is the work of the cancer registries, and there is an active programme going on this year in terms of modernising the cancer registries. One key element of that is all the registries are moving to a single system, and that will be achieved by the end of this year. That system's called Encore. Once that is in place, that will improve both the timeliness of registration and the completeness of case ascertainment, which is absolutely vital information. Another key piece of information for us is the stage of diagnosis, and the objective is that by the end of the year we'll have accurate comparable staging on at least 70% of all cancer patients. We also need to ensure that the collection of data is as robust and as comprehensive as possible. And so we're focusing on the development of cancer outcomes and services data set and chemotherapy data set, which became live on the 1st of April of this year. We're looking at new analyses, for example, emergency presentations, why people are presenting as an emergency, what are the numbers involved there. We're looking at the numbers of survivors and the kind of treatments that those survivors receive. We're looking at links, various linkages, including, for example, linkages between those with a mental health disorder and those who are diagnosed with cancer. And later on, Andy's going to talk a bit more about the various profiles that we've been developing, GP profiles, which many of you may know about. But now we have service profiles as well, and Andy's going to be giving us a bit more detail about that. In terms of the rest of the things that I want to say, in terms of the challenges and priorities for cancer services, I'm just going to frame that around the 5 domains of the outcomes framework. So the first one then about reducing mortality and improving survival. The incidence of cancer in this country is rising all the time. At the moment, it's about 265,000 new cases each year, and it's anticipated by 2030 that number will have increased up to about 300,000. And we have seen in this country significant improvements in survival and mortality. And much of that, I think, you could link back to the development of the multidisciplinary teams and the impact that they've had in the care and treatment that's provided. But despite that, the survival in this country is far poorer than in many other countries. And we've been doing some international benchmarking work in collaboration with the Department of Health and CSR UK, looking at how our survival rates compare with a number of countries in Europe, which include Sweden, Norway and Denmark, and how we compare with parts of Australia and parts of Canada. And it doesn't paint a very encouraging picture, which I'll show you in a moment. The major factor, we think, for poor survival in this country, though, is late diagnosis. And therefore, the focus needs to be on increasing the awareness of the signs and symptoms of cancer and ensuring that there's access to diagnostic facilities and so on, so that we are diagnosing much earlier than we're doing at the moment. I hope that you can just see the overall picture at the back of the room. But this is survival at 5 years, and it compares where we are with those partner countries that I've mentioned as part of the benchmarking exercise. And you can see that in 3 out of the 4 cases, the UK, which is the black line, is at the bottom of the graph. The one exception is that we're just above Denmark in terms of ovarian cancer. The other thing to point out is that survival is improving. The slope is on the up. But the problem is that with the possible exception, well, the exception of breast and the possible exception of ovarian, the gap between where we are and where those other countries are is not narrowing. And in fact, in lung cancer, you can see that the gap is widening. And part of the work that we're doing around this benchmarking project is to understand why that is happening, why those gaps are there, and what we can do in order to narrow the gap that we're currently seeing. If you look at the picture, and some of you will have seen these next 3 slides before, but this is the position in terms of 1-year survival in PCTs across the country. And the line across the middle, that blue line, across the top there, is the international best practice. And so as far as breast cancer is concerned, in terms of 1-year survival, there are only 7 PCTs in this country that are above the international best practice on 1-year breast survival. For those of you in London, you can see there aren't any that are above that line. The other interesting thing to note is look at the range between the different PCTs in London, a very large range. The next one is lung cancer. In this case, there's only 1 PCT that's above international best practice. That happens to be in London. See me afterwards if you want to know where it is. Don't ask me now because I'm not sure. I really have to check. But only 1 PCT that's above the line. And then finally, looking at colorectal, Again, 1 PCT in the West Midlands is above the line. But again, look at the range, the variation in one-year survival in London. So there is improvement in terms of the numbers of people surviving, but in terms of how we compare with others, we're not narrowing the gap. And as I've already mentioned, when we're talking about trying to save lives, we're not just talking about buying people a few extra weeks, a few months. We're talking about the difference between early death and long-term survival. So, the other thing that I mentioned earlier in terms of investment is that we believe that initiatives to promote early diagnosis are likely to be particularly cost-effective. And there are a number of areas that we think we need to focus on. One of those is reducing the number of people who are diagnosed with cancer as an emergency presentation. There is evidence that shows that people that are diagnosed through that route have a far poorer chance of survival than people who are diagnosed in other ways. And currently around 25% of all cancers are diagnosed as emergencies. So that's an area that we clearly need to look at. Another area that we need to focus on is elderly patients. Again, there is evidence that patients who are elderly go to their GP late. And we need to find ways of encouraging them to go much earlier, to get over this, well, I can't bother the doctor. I'm sure it's a problem that will go away. We need to make sure that there's earlier presentation, particularly amongst the elderly population. And we need to ensure that providers record staging at diagnosis. And if Mike Richards was here, he would be going as far as saying, if providers can't record stage, then they shouldn't be paid. So, NADI, which stands, for those of you who don't know, is the National Awareness and Early Diagnosis Initiative, focuses on a number of different areas which I've listed there. Awareness campaigns I'll talk about in a moment. Supporting GPs on earlier diagnosis. That's for things like development of risk assessment tools, which we've been working on, again in collaboration with the Department of Health, to look at what tools will help GPs make an assessment as to whether or not the patient sat in their surgery needs to be referred to hospital. Improving access to diagnostic tools like chest x-rays and so on. Endoscopies, again, is something that we need to look at, how we can increase the capacity for endoscopies in this country. If you look at the number of endoscopies that we're undertaking, we compare poorly with places like Poland and, dare I say it, Scotland. So we need to think about how we can increase the use of endoscopy. And finally, that comment that I made earlier about focusing on emergency presentations. So in terms of raising public awareness, we currently have a national campaign around lung cancer. How many people in the room have seen or heard the lung campaign? Okay, well that's about half of you, I think. So that campaign is running for the rest of this month and for next month. We've previously had an awareness campaign around bowel cancer. How many people saw the bowel cancer pain? Okay, yeah, good. And we're looking to repeat that in September. We've got various constraints on us this year in terms of awareness campaigns. We're not allowed to do anything during the Olympics or the Paralympics. And we try not to do things in the summer holidays anyway. So that limits the kind of time that we have available to run these campaigns. But September will be what they're calling the stretch of the bowel campaign. And then we're looking at 2 regional campaigns early in 2013. I have to say that this is subject to Cabinet Office approval, but once that approval is received, we're looking to run a campaign around blood in urine, and this slide says breast cancer in over 70s or esophagogastric. In fact, it's not esophagogastric, it's going to be breast cancer in the over 70s. And we're looking at how we might run a campaign that doesn't necessarily involve the use of TV. With regard to local activities, one of the things that we're wanting to focus on this year is how we can support GP leadership and engagement, particularly around discussions with GP practices about their profiles, about their referral patterns, how they can do things differently. And there are now GP leaders identified in most networks, but if you think there are 8,000 plus practices in this country. It's how we can support GPs engage with those practices, and we're doing a piece of work around that with CRUK. We're also looking at possibility of identifying new sites where we might be looking at raising awareness campaigns, and that includes ovarian and what we're calling a constellation of symptoms. So raising public awareness is seen as a very important activity for us and for the department as a way of tackling this issue of late diagnosis. If we move on then to the second domain, which is about improving the quality of life with people with a long-term condition, there is an ever-increasing number of people who are living with and beyond a diagnosis of cancer. But I think it's fair to say that the services that we've been providing for that group of patients, the information that we have about that group of patients in terms of their ongoing needs, the support that they require, has not been as good as it should be. And so there are a number of objectives that we've set in terms of the improvements that we want to see in the care and support of what's defined as survivors of cancer. We want to reduce ill health associated with cancer treatment, the ill health that comes as a result of radiotherapy treatments, for example. We want to reduce the risks of recurrent cancer. We want to reduce the number of people who have unmet psychological support needs. And we want to increase the number of people who are able to get back to work and with whatever support they need in order to do that. And so we're working particularly with Macmillan and NHS Improvement to address a number of initiatives around the survivorship programme. And it includes, and I won't go through the list, but it includes the kind of things that you see on the slide before you. So that's around improving the quality of life. In terms of enhancing recovery, which is the third domain, the main thing I think that we want to achieve is ensuring that patients receive appropriate, high-quality treatment provided by clinicians with the appropriate skills and the right level of experience in order to provide that treatment. And we want to ensure that that accessibility to appropriate treatment is available to everybody, no matter where they live. So one of the things that we want to do, and this is a commitment in the Improving Outcomes strategy, is to promote the uptake of the latest surgical techniques. And an example of that would be work that we've been doing in terms of a laparoscopic training programme across the country to ensure that that kind of surgery is available again across the country. We want to improve intervention rates for elderly people so that we ensure that decisions about treatment are based on likely outcomes and not decisions that are based on the age alone of a patient. I've already mentioned the enhanced recovery programs, and to date we focused on colorectal surgery, enhanced recovery programs around that treatment. What we want to ensure is that those programs are extended and are available for a whole range of surgical interventions. We want to increase overnight breast surgery, which has been a great success in this country. And as I've already said, we want to look at ways in which we can reduce unnecessary admissions, but where those admissions are necessary, we reduce lengths of stay. The fourth domain is around the patient's experience survey that's conducted for cancer patients, and you're not supposed to be able to read this, you'll be pleased to hear. But this was a survey that was undertaken. 67 questions were asked. We had a fantastic response rate of 67,000 people, and we're currently repeating that exercise. And at the moment we're undertaking an analysis of the responses that we've received to a very similar set of questions, and that information, or the results of that analysis, will be available, I think, back end of July or during the summer. What we need to do is to move we need to move trusts that are predominantly red, which is where you don't want to be, to green. And we want to look at why patients are reporting poor experiences in certain places, why it is that some trusts have a culture of really good patient experience and other trusts less so, what impact does having a named clinical nurse specialist have on the experience that a patient has. And we think there are a number of interventions that can be provided in order to improve patient experience. Better information for patients would be one, about the treatment options, about the support that might be available for them, about the financial support that they might require. Improved communication skills training, and many of you in the room will be aware of the Advanced Communications Programme that NCAT has been sponsoring over the last couple of years. Because it's not just good enough to give a patient a leaflet and say, there you are, go away and read that. The leaflets should just be something that supports the conversation that happens between a clinician and a patient. And we need to make sure that our clinicians have the right communication skills to make those discussions meaningful and effective. Better MDT working. I've already said that I think a significant progress in this country has been the development of multidisciplinary team working. But what we need to do now is to make sure that those teams are working effectively, that they have good leadership. And we're introducing a programme that we believe will support better MDT working. And I've already made brief reference to the importance of the role of the clinical nurse specialist, a role that in recent times has come under quite a lot of threat because CNSs are being asked to undertake more and more in the way of ward duties. When CNSs are going, they're not, in some cases, replaced. But there is clear evidence that there is a strong link between the role and support of a CNS and good patient experience. So we need to turn red teams to green. And the final domain then around improving safety. We need to be able to measure the safety, and we've been doing some work around 30-day mortality after surgery. We need to ensure that services such as chemotherapy that we're providing are safe and effective, and things like the development of the acute oncology services are in support of that. And the peer review programme is an absolute vital element, we believe, in identifying immediate risks, serious concerns, and acting upon those risks, but also actually identifying where there is really excellent safe practice information that we can share and disseminate with others. So that's a rattle through the 5 domains. Just in summary, about what we think commissioners can do now. Firstly, we believe, I hope I'm not repeating this too often, but invest in early diagnosis is an absolute key. Ensure providers record stage. Monitor the number of patients that are presenting as emergencies, and look at ways of reducing emergency admissions of existing cancer patients through proactive support, such as having well-established acute oncology services. I think the other thing that we would want to say is, if you are someone sat in this room who is going to have responsibility for commissioning in the future, you are not on your own. We were talking to a GP on Tuesday in Leeds who said it just seems overwhelming at the moment and very daunting, all that we're being asked to take on board. You're talking to us about cancer services, but it's only one disease group. Well, one of the things that we want to stress is that we believe that we can help you in that task, both from a national point of view and from a local point of view through cancer networks or through others who are experienced in commissioning and planning cancer services. And so it's important that you engage with us, and we have the opportunity to engage with you, whether we're from a network or a national team, to identify what support you require and how that can best be provided. So in summary, I think that we're making steady progress on cancer generally, but we're not there yet. We're not there yet. We still have a significant way to travel if we're going to realise that ambition of delivering outcomes that match the best in the world. And we have to retain a focus on the key priorities that I've tried to highlight this morning. And we need to make progress towards realisation of those goals, despite the uncertainties that we're facing at the moment and despite the financial constraints that we're working within. So thank you very much for listening.